Hello, thank you for joining the community information session on spina bifida transition care, sexual function, and pregnancy. The session will include information about transitional urology and when to consider transition, and adult urological issues, bladder and bowel management, prostate enlargement, sexual function, pregnancy, and pelvic organ prolapse. My name is Judy Thibodeau, and I'm a member of SBA staff. I'm joined by my colleague, Juanita Panliner, SBA's National Resource Manager. I want to mention a few things before we get started. You'll remain muted throughout the session. You're welcome to submit questions using the Q&A feature on Zoom. If time allows, the speaker will respond to the questions. Those not answered will be included in the Ask the Expert session, which will be held on Tuesday, July 30th at 7 p.m. Eastern Daylight Time. Everyone who registered for this event will receive a link to the recording of the event. Closed captioning is enabled. If you have any technical issues, please send a text to Juanita at 202-487-3988. The session is being recorded. And now I'd like to appreciate the support of tonight's sponsors, Atidnas, WellSpect, and Hollister. Now I'm pleased to introduce today's speaker. Dr. Melissa Kaufman is Professor of Urologic Surgery and Chief of the Division of Reconstructive Urology and Pelvic Health at Vanderbilt Medical Center. Her practice focuses on female and male voiding dysfunction and incontinence, cancer survivorship, pelvic organ prolapse, neurourology, transitional care for congenital urologic conditions, urologic prosthetics, transgender surgery, as well as reconstructive surgery for urethral stricture, fistula, and trauma. We are pleased to have Dr. Kaufman with us today. Dr. Kaufman.
Thank you so much, Judy, and thank you to the Spina Bifida Association for giving me a little bit of a platform to help discuss issues that may be of importance for everyone engaged on this webinar. Because really, we're all working for the same goals, right? And the goals really are because boys and girls with spina bifida, from a pediatric perspective, I work in the adult world, they grow up to be men and women, which is a fabulous thing. This is remarkable. And in history of urology, I'm really the first generation that's had a marvelous opportunity to engage with adults with spina bifida and begin to explore a lot of these topics that we are going to discuss today. And I highly, highly encourage you to ask questions in the chat, put them in the question and answer, or save them for our next session in 2 weeks, where we'll have more of a conversational opportunity. But I just wanted to introduce some concepts and some of the ways that we go about evaluating issues and some of the issues. And we're going to talk about things that everyone has questions about, things like urinary infection, things about sexual function, and things about pregnancy. These are very, very common questions that I get from an adult perspective, and I want to shed some light and demystify some of these issues. So we'll talk a little bit about what does transitional urology in specific means, and when's it appropriate, and how do you do this? Like, what's the best way to transition to an adult urologist? We do talk a little bit. There's a lot of considerations because some of them happen to almost everybody. Most people at some point are going to have some issues with bladder management, whether you have spina bifida or not as an adult. Everybody has issues at some point and wants to discuss things about prostate enlargement if you're a man or sexual function. So all these things we're going to touch upon today, but I want you to know that it's an open door for you to ask questions. I want to be able to address the things that you are thinking about that we can help demystify. So we know children with spina bifida now grow to be adults, but 2/3 of people with spina bifida don't have urology follow-up, although there is a great need because of urologic issues that have happened from birth. And so in transitional urology, the goal is really to build expectations and provide tools for people to self-manage. We also oftentimes are the primary providers for a lot of general health concerns and can help navigate the system, because pediatric providers don't usually address a lot of sexual issues for good reason, right? These are not the times to bring up these topics, but these are very, very natural questions for teens, young adults, and frankly, I see patients across a really broad range, including much older adults, and they remain big issues that we can help with. So the problem is really finding a urologist who understands your problems. And this can oftentimes be a big barrier. So I encourage you to ask, to use the resources from the Spina Bifida Association, to reach out to me where I can maybe help you find somebody in your area that can give you guidance to address some of these issues. So transitional urology in general is subspecialty care, but it focuses on adolescents and adults who have chronic urologic issues from birth. So that means congenital, something that you're born with. And it really requires a specialty expertise and somebody who has given a lot of thought and attention and has experience with patients who come in and have some of these issues. Because we all know everybody's unique, right? Every anatomy is unique. And you want to have someone who is really somewhat familiar with some of the things that might have gone on when you were 2 years old and have knowledge of these long-term effects of all these prior interventions and operations. And so part of that comes back to you being able to transmit that information really well. You know, at Vanderbilt, I can tell you what we did was we combined clinics. We had a clinic in our pediatric hospital where I would go over to meet patients and help develop those relationships. But it was in a very known structure, but it opened the door to address a lot of adult specific issues. And so, you know, what do parents and patients want to know? We needed to ask these questions because some of them are really not unique to spina bifida. They're just what everybody's asking, and you should be asking them too. And having spina bifida is not inclusive of all the things that you might want to discuss. The things that we need to discuss always are from a urology perspective, and urology deals with the kidneys, the drainage tubes, the kidneys, the bladder. We deal with issues with the penis. We deal with issues with testicles, all these organs that are part of our purview, you know, but the major issue that comes in when you have issues from childbirth really do with the kidney function. We want to make sure we've done everything we can and help you develop good tools to preserve kidney function, because that in and of itself, it can set a different course, and we're all aware of this. Of course, bowel and urine leakage are oftentimes very troublesome, huge quality of life issues, and then they can cause other problems. And so we want to do everything we can to help preserve what we call continence, which is not having as much leakage. And again, looking at all the different types of reconstructions that might have occurred to help some of these issues. And these can be over decades and decades of time. And so really, you may need a lot of adult providers, not just a urologist. There are other things that we can help with by getting you locked into people, social work that can help with insurance issues. These are often really barriers to getting good treatment. And then sexual and reproductive health. As adults, this is an important part of who we are. It is an important aspect, and I encourage you to discuss it. even people without spina bifida have a lot of issues discussing these types of concerns with providers. And so when there's all these other overriding things, you think that's going to be last on the list. But really, sometimes it comes up first on the list, and we need to be able to talk about it before it comes up first on the list, so we can then help you navigate some of the complexities. So your initial visit with an adult provider, we're going to talk about current problems that you may be having. Maybe you're not having any. That's great. Maybe you just need to get an order for a particular catheter. Maybe you just need to get a follow-up order for an ultrasound or kidney function test. But I also want to know a little bit about you, right? What are your goals? What are your plans to do? Like, how can we help you identify ways to make those issues with your life successful? Because really, isn't that what this is all about in the end? Is that you have your goals of what you want to accomplish, and how can we as providers give you tools or give you counseling that helps you help yourself to do what it is you want to do? And who are the other people that are going to be part of this picture? Your significant other, maybe your kids, maybe other people who are caring for you, maybe your parents. We don't know, but we need to have us all on the same team so we can be working towards these goals. And really, most of the time, these are quality of life concerns, and we want everyone to have the best quality of life possible. None of us know, what the quantity always will be, but we want to optimize that quality. So it's very important to get as detailed a review as possible of all the prior surgeries and interventions and things. And obviously, you're going to give signed medical releases for records. But if you have these records, and I encourage a lot of people to carry a folder or binder, or nowadays everybody has these little USB stick drives where you can put all this information all at once and then be able to carry it around and have it for everybody who may need it, especially if there's ever an urgent type of situation, then your entire history is readily available. Because really, this is true for lots and lots of people who transition with things that happen near birth to adulthood. They have to have and we don't always have all the records in our system, despite the fact that it looks that way. And sometimes those systems don't work very well at all, as I think we've probably all found out at some point. But we want to assess a number of things. And so we'll ask some questions, and I don't want ever anyone to feel uncomfortable with this line of questioning, but I do want you to know that these are very intimate issues, and that I want to be respectful, because sometimes there can have been a lot that has gone on regarding these very personal issues over time. And so if ever you feel that a provider who's just trying to get information so they can help treat you has made you anyway uncomfortable, just let them know. It's very, very, we all want it to be a very open environment, and we want you to feel completely comfortable sharing whatever information you feel comfortable sharing. So if there's issues or goals with your sexual function, if there's issues or goals with fertility, and we're going to definitely ask about bladder management, about bowel management, about if you've ever had kidney stones, all these things can become very important when we talk about treatment plans or how we're going to devise that from a urology perspective. So when do people consider transitioning? Age is not really always a good criteria. Everybody's got to mutually agree when these urology issues are more adult in nature. Oftentimes that comes around young adulthood, late adolescence, and young adulthood. But sometimes it can occur later. But don't ever feel abandoned by the pediatric urologist or pediatrician, because we really, the adult urologist just wants to be able to have a conversation in a different realm and a different context. And it is certainly not that the the urologist who has probably, been with you since birth, who adores you and who you adore and who have been through a lot of together. They want the best for you for the next 60, 70, 80 years of your life, right? And so moving to an adult urologist at some point, when it's appropriate, and that level of appropriateness can be in a very good conversation that you have with all the parties involved. So you also need to be able, as I mentioned before, find a urologist who has a subspecialty interest in this kind of thing, transitional care. So it can happen just sometimes by chance if you move, if you get a new job, go somewhere else, have different insurance, get married, and wherever it's reasonable to change a medical care venue. So again, first discuss everything with all the key players, your urologist, your family, other caregivers, get all the records together, keep a copy, have all the prior interventions, all the x-rays, all the lab tests, and then ask for a referral, ask your primary care provider, ask your urologist for a referral, consult the Spina Bifida Association, the incredible wealth of resources that you can utilize and tap into. And the fact that you're here today, spread the word, right? The fact you're here today makes me recognize that most of the people on this particular webinar know what kind of rich resources that you have available to help for these types of transitions. And talk to your other care providers. They may have experience, your neurosurgeon, orthopedic surgeons, other people who know someone that may be able to help. But I want you to think about what your goals are. I want everybody to think about that. And if you don't have that full history, bring somebody with you who can help out, because sometimes none of us can remember everything, right? And oftentimes I think it's helpful, request the last appointment slot of the day. I mean, nobody really wants to go to the doctor at 3:30, or request a double slot. Say, I'm a new patient, but I have a really complicated history, and I'd like to be able to spend time with the doctor discussing all my concerns. And so just ask. It's that simple. So what are some of the dilemmas from a urology perspective that we run into? So sometimes they're just unknowns. And that's the case with everything, isn't it? Sometimes we can't get to records. We know that something happened at some point, and maybe there was a surgery here or a surgery there, or maybe there was an intervention, or maybe there was a hospitalization for something else. That's okay. Do your best to try to recall that. If you can't have all that information, though, and somebody is not going to be able to be there who may have a little bit of extra information and recall, that can be a dilemma. And so we'll often either ask, send with specific questions that we need answered that are going to help you, and for you to take back to get a caregiver or someone who may have other information that couldn't come to the visit that day with you. There's also a lot of different techniques that are used out there. And so we can't ever really be certain exactly what happened. And sometimes there are historical treatments that were done for decades, but are not done anymore as our knowledge has increased and we've moved along to different types of treatment strategies. And, adults, I guess you've probably heard this before, adults are not just big children. There's a lot of other things that change. And occasionally we set up different types of routines, and we all love our routines, and we get set in a routine. But then as we age, things change and size changes, and we need to accommodate, and we don't always do that. And we think, well, we've been doing it like this forever, and so it's going to work like this forever. So what's going to happen? What are the routine things that are going to happen? Well, probably you're going to get a careful history and exam. we're going to look at some of the kidney function labs. Certainly when you first come in, you'll have some imaging tests done, and that's typically just a renal ultrasound. But sometimes there's a lot of bladder issues, and we need to make sure that they're not impacting anything about kidney function. So we'll do some other testing. And this testing I want to talk to you about is called a urodynamic testing. So it's a dynamic or like functional test of the urinary tract. And we do this whenever there are new symptoms, probably for a baseline in most people who come in with spina bifida. And then if there's any change in symptoms, so if you have diagnosed with tethered cord, if you have a change in leakage of bladder or bowel, if you begin having kidney issues. We also may take a small light scope to look into the bladder, even if there's been reconstructions like augmentations there, to look for any, if there's new symptoms. But much of this may begin as baseline.
Dr.
This is
Kaufman,
yes.
Dr. Kaufman, hi, sorry, I'm jumping in.
Oh, no, please do.
Before we move on, there was a question that I think relates to your last slide. This is from a woman who is in her early 60s, and she explains that she lost the function of one of her kidneys at age 13 due to reflux from an inability to void from age 6, but she wasn't diagnosed at that time. So she's currently followed by a urologist, but wants to know if she should request a nephrologist. The urologist, I guess, does periodic ultrasounds, and she doesn't want to lose her one good kidney.
That's a great question. And so this is exactly why we do these types of evaluations on patients very early, and that urodynamic testing that I'm going to talk about can really help sometimes spare these things. We know this now. I mean, that was many, many years ago that all that transpired. And I'm sorry that transpired for you to make it to make you super vigilant, though. I appreciate you're super vigilant about taking care of your remaining solitary kidney. So we want to do everything we can to prophylax against that. I would rely on your urologist knowing how you're managing your bladder, knowing if there's putting any pressure on that kidney, and doing serial ultrasounds and the kidney function test. I'm entirely positive if there was any signal that you could benefit from having a medicine doctor like a nephrologist on board to help that kidney, that they probably would send you along there. So it's not mandated that you do that. Let's think about what happens, say, to kidney transplant patients or patients who donate a kidney for transplant. Many, many people can live very, very successfully with single kidney. So it's not, and some people are just born with a single kidney and they do fine and they would never know. So just having a single kidney doesn't necessarily mean that you need to see a nephrologist or that you're at any risk at all. And I think that if you're being monitored really carefully, that's probably the best option. But we will often do these urodynamic tests early on to try to discern, is there reflux? Is the kidney at risk? And this is a typical urodynamic setup. I wanted to show it to everybody to kind of demystify. It looks very complicated and it looks very scary, but in fact, they're quite routine and many patients do it. And they, although are reticent at the beginning, the vast majority of people tolerate it very, very, very well. And we put in catheters put in bladder catheters, sometimes vaginal catheters, sometimes rectal catheters to be able to measure all these pressures. And then on that computer system, we will instill water into the bladder and we will determine whether and take x-rays at the same time, determine whether it's a safe place or why you're having leakage, if you're having leakage, and determine if there's issues where they're putting pressure on the kidneys, like what you were talking about before with reflux. This is a typical tracing that we see, and these are pressure monitors, and this is a patient and you can see these big spikes are actually pressures that are happening in the bladder. It's like spasms, like having a Charlie horse in your calf. This can often come with any kind of neurologic problems with the bladder, and these can cause leakage. But this is a very common scenario that we see. And when we see these things and you have issues with the bladder, I know that many of you are going to be familiar with medications for the bladder. And there's several different classes of medications, and I want to discuss them with you because I want to understand what some of the options, limitations, and side effects of those are. There's a very common class of medications that most people get from the time they are very small called anticholinergics. We have newer medications called beta-3 agonists that have less side effect profile and may work even the same way as as effectively as the anticholinergics. And then there's other types of medications that may have been used in you over time as well that are specific for the bladder. But I want to speak to this group about these anticholinergics that are used for bladder, because it's come to the attention of providers in recent years that long-term use, sometimes even short-term use of these, can precipitate issues because they can cause cognitive decline. So decrease the ability to think clearly and may even represent risk for dementia. And we know that many people have been on these medications for long periods of time to try to control bladder symptoms. And so how are we best counseling people? What do we do? Well, we know that it may be associated with a risk of actual dementia, and that short-term use is likely safe. So we will oftentimes use different medications like the beta-3 agonists that we discussed. There's typically, these are preferred. Sometimes we can't, people can't afford them because they're very expensive. We can't get insurance coverage, but we will try and do everything we can to make that happen. There's a medication called Oxybutynin in immediate release, or Ditropan, that most people are familiar with. And overall, in general, we suggest this be avoided. But this was the most commonly prescribed medication for decades and decades and decades because it was all anybody had. And so we didn't know about these risks. But we wanted everybody to know that it's a potential risk. And we may want to talk about, and I will talk about a little bit more early on in the process, moving to advanced therapies, things like Botox injection or pacemaker devices, in order to control symptoms, in order to reduce the risk of these medications. So I think it's really important for everybody with spina bifida who may have gotten bladder medications to have this information and know it. And when we talk about Botox, this is a medication that people use for facial cosmetics, but it's also used for other types of muscle spasticity. And we use it with injections in the bladder to treat these kind of bladder spasms that can, and so we eliminate the oral medications that cause these other issues. So if you can't tolerate or don't have a good response to all those different agents, we'll oftentimes suggest using Botox, which we can put in the clinic in a short procedure with a small light scope. But why does kidney damage often occur? As you mentioned before, reflux, so high bladder pressures during storage can impair drainage. Sometimes the urine can go back up, which is the reflux. And if there's incomplete emptying of the bladder, it can increase these pressures and basically provide an environment where stones can form. And on stones, bacteria like to hide. So every type of bladder management can cause reflux, whether you're catheterizing or have a catheter or have some other type of diversion, but it gets much more rare when you have a really good drainage system for the bladder. And those little cartoons are just showing a cartoon of the kidney And then when you get reflux, it swells. And so when you have kidney swelling, this is called hydronephrosis, and that's the dilation of the kidney. And you see as that happens, the actual functioning portion of the kidney thins out quite a bit, so it will function less. And then when you have reflux and infected urine, it increases your risk of kidney infections and predisposes to kidney stones. And then this goes into a really vicious cycle. So our goals, and the reason we do that type of testing, is we need to know, is this happening? Because we have to do everything we can to lower these bladder storage pressures and reduce the risk on your kidneys. And of course, everybody's at risk for kidney stones if you're not emptying your bladder all the way. If you have reflux, if you have infections, immobility, and diet and hydration status are the #1 reasons everybody, whether you have spina bifida or not, gets kidney stones. Diet and hydration status. So that means salt and water, water, water. Now, about 30% of patients who have neurogenic, the NLUTD is our terminology in urology for neurogenic lower urinary tract dysfunction. So issues with the bladder in general. So about 30% of patients who have neurogenic or issues with the bladder secondary to neurologic causes get a urinary tract infection every year. But very, very few of those actually progress to infections that get into the kidneys of the bloodstream. Having a lot of urine left in the bladder is a known risk factor for both stones and urinary infections. So sometimes when we have infections, we will ask for increased frequency of catheterization. We really just want to maintain everything at a very low pressure. And I use a lot of non-antibiotic prophylaxis. So I'm a big believer in avoiding antibiotics unless we absolutely need them, because we have a lot of antibiotic resistant organisms. So we want to do everything we can. Sometimes you need antibiotics, but we want to do everything we can before we use those. So one of the things is what we call pH. So this is the acid-base balance in the urine. I really want to manipulate that to decrease bacterial growth. Also, you use cranberry supplements that have this really long word, proanthocyanidin, but it's a specific agent that helps bind to the receptors that the bacteria bind to adhere to the bladder. Sometimes mannose, it also works that way. Probiotics for bowel health to keep those organisms that may colonize the urinary tract inadvertently away. And then for women who have near menopause, gone through menopause, older women, vaginal application of estrogen can be a huge factor to help prevent urinary tract infections. So methenamine works as an antiseptic, and it actually lowers the risk of infection because in acidic urine, an ascorbic acid is vitamin C. So we give this medication with vitamin C, and what it does is it breaks apart and actually makes formaldehyde, which is kind of a pickling agent that will decrease bacterial growth in the urine. So I'll give this medication, Hiprex, and it's twice a day, methenamine and with vitamin C. This combination that can really reduce the amount of bacteria in the urine and no antibiotics involved at all. Other things that we use, there are oftentimes there's going to be vaccines that come out in the future. There are other types of really sophisticated agents, but in general, we just I just want to express that all this non-antibiotic prophylaxis is our first line of therapy. But we do use antibiotics. My #1 way of using them without using oral antibiotics is actually in irrigations in the bladder. So especially for somebody who's already performing intermittent catheterization, this can be a great way to instill some antibiotics very locally where it won't have a systemic effect, but still get a good response in reducing, again, the bacterial burden in this environment. Multiple times a week, we give you a recipe and give you the antibiotic solution, and you just instill it in the bladder. And we can use several different types of antibiotics if it's needed to do. Now, every once in a while, most of what patients will have been on a prophylactic antibiotic, which means that you're taking it every day and have been for long, long periods of time, and may be getting breakthrough infections. So it's very controversial about using these because it can cause, as I mentioned, a lot of collateral damage. It can cause multi-drug resistance. I try to just say no when possible. Sometimes if there's other complexities like immune compromise, kidney transplant, we can't avoid it. But I only really just want you to think about treating culture-specific infections that have new symptoms associated with them.
I'm going to jump in again.
Yes.
Dr. Kaufman, yes, there's a question, and I'm not sure if you need more information in order to answer it, but the question is that this person is currently taking Oxybutynin,
Yes.
and they would like to know, what medications do you suggest?
I thank you for that question. So I typically now only use 3 different medications in my practice. One of them is similar to Oxybutynin, and it's called trospium, and it can be dosed twice a day. It's a very affordable medication. And the reason that I use that is because it does not cross into the blood-brain barrier, and therefore doesn't cause some of the same cognition symptoms that the other anticholinergics like Oxybutynin can cause. I also use both of the beta-3 agonist medications, and that's just the terminology of how they work. But one of them is called Vibegron, and the other was Mirabegron. So those 3 medications are my primary go-tos for all types of bladder issues. And I almost exclusively use those unless there are really, really extenuating circumstances about patient stability. And we've had the conversation about the potential risks of using those other medications. I do use Oxybutynin short term for patients after different types of interventions, but I typically don't use it long term.
And I'll go ahead and I'll put this. Oh,
Yeah.
thank you so much. I'll put
Yeah.
those in the chat, but I just wanted to double check
Yeah.
the names with you again. One was trospium,
trospium, Vibegron, and Mirabegron.
Okay. All right. Very good. I'll look them up and put them in the chat in case people are
Thank
curious.
you.
What was it? The last one, Migra?
Mirabegron.
Ooh, sorry. Okay. All right. Thank you so much.
You bet. I can have more information when we do our Q&A session too. So in general, I was part of a guideline panel for neurogenic lower urinary tract dysfunction. And really what it comes down to is that we assume the best, but we have to be vigilant for the worst. So we want to have good follow-up and document things as much as possible about frequency of infections, about incontinence. And after we do our baseline workup, if there's no concerning findings, then we will let your history trigger what needs to come next. So if you come in with a new issue or a concern, then we may do further diagnostics or testing. But it's based on your needs and your concerns and the things that are happening directly to you. But we talk about, as adults, sexual function, and sex is complex for everybody, spina bifida or no. You know, a lot of the initial information was based on males, as it was for all types of sexual function. And we don't really know what's adaptable to everybody, since every single individual is unique, and certainly every individual with spina bifida has a unique set of challenges. But we do know from data that the vast majority of people with spina bifida, just like everybody else, are interested in learning about it, are interested in participating. And interestingly, there's a very little relationship, even with continence, to sexual function. So there's a lot of non-traditional concepts that we have to accept, and that everybody's individual experience and response to stimuli is not what everybody thinks is potentially typical, but it's yours, right? And so it's valid, and it's worthy of exploration, and it's worthy of knowledge. So there's just different strokes for different folks. But we have to be educated about it, right? It's a little bit, there are impairments to overcome, and some of those have to do with parental conflict that we often see in our society build up that helps people express sexual behaviors. But another thing is something called precocious puberty. So some women with spina bifida, because of hormonal changes, will start puberty very, very early. So I think that it's important that everybody knows that, and that pediatric, providers let everybody know that, because it can be disconcerting, and we want to have those conversations, that transitional conversation, very early. When we looked at this data, most everyone with spina bifida has similar desires and outlooks to everyone else in the population. It's not anything unique, and the majority were in intimate relationships. But most people decided or determined that they didn't have adequate knowledge. Now, I can tell you that may really not be unique to spina bifida, but I think it's more prevalent, because I think that people are reticent to discuss, and I think it's not high on the minds of a lot of providers who are talking to you in general. And a small percentage really bring up. Again, these are really intimate topics that can be very, very difficult to broach with providers. So find somebody who's comfortable. If you want to talk about this, find somebody who can address your questions. And again, urology and sometimes gynecology can often assist. For men, and I see a lot of men with spina bifida, it's very similar. They have normal testosterone in general. They have the same desires and interests as all the other colleagues of their same age group. Many have problems because of the erections require really delicate balance of nerve input. And so a lot will have problems with that, but we have so many ways to overcome that. And the good news is that many people have very high paternity rates. So it's not difficult to get someone pregnant. But do know that many condoms and things like that have latex. And so if you have an identified latex allergy, which many patients who've been in the medical system have, that just be wary of that. But do use birth control. For women, there can be problems with having menstrual periods. There can be problems that you're born with inadequate support of some of the muscles in the pelvic floor that can cause hernias of the bladder and bowel, which is what prolapse, so the organs in the pelvis can kind of bulge out in the vagina. There's also latex allergies because of some of the pathways for the nerve endings that aren't expressed. There can be problems with lubrication in the vagina, but there are lots and lots of assisted fertility options. But let me just tell you, in general, women with spina bifida have normal fertility, and they don't know that. Most people don't know that. It's never discussed. You need to think about, sexually transmitted infections and birth control. Sometimes there's issues because of all the prior surgeries, and sometimes there's issues from those hernias. But I want to be able to have these conversations with you before you decide that you want to get pregnant, because we have to have a knowledgeable group on board to help. And if you do think about getting pregnant and you've had any kind of reconstruction, particularly a bladder augmentation, where there's bowel and contact with urine, don't trust home test kits. So you need to get a blood serum HCG test, because those urine pregnancy tests, if you have bladder augmentation, just don't work well. And you want to do everything you can to decrease risk of transmission. So in general, you have risks. These are genetic conditions. There's a genetic component. And if both parents are affected, it's up to a 15% risk. On the global population, we ask women to take 0.4 milligrams of folic acid 3 months prior to conception, all the way up through week 12 of pregnancy. But in spina bifida patients, we're going to ask you to take 10 times as much. So it's really important to supplement with folic acid to prevent transmission or any problems for your baby. And there's lots of unique challenges with pregnancy. Sometimes they can be about your age. Sometimes things happen when you're a little older. Sometimes you've got other types of urinary issues, or you've had these reconstructions, or you have different anatomy, or it's going to be complicated to care for a baby. You know, these things are not always unique. And you really want to address them and try to find ways to address them before pregnancy, just so you're ready and prepared, because you can be a successful parent. You can do all the things that everyone has the opportunity to do. It's just going to require more effort on your part to get everything in line to begin the process. Because sometimes things change. You know, you have this big baby in the uterus, and if you have a shunt, it can change the drainage of the shunt. If you're using a channel in the abdomen, it can change how that's used. It can change the skin because you've got something big pushing up on your lungs and your heart. It can change some of those things. And there's always a risk for urinary infections during pregnancy as well. So if you're catheterizing during pregnancy, there's always going to be bacteria. You know, if you have a bladder augmentation, there's always bacteria around. So this is the one time when I might agree that using antibiotics in suppressive fashion really reduces your risk. Because if you get a kidney infection or pyelonephritis during pregnancy, lots of really devastating things can happen, like preterm labor. There's just danger to the baby. So a lot of providers, and we talk very closely with high-risk obstetricians, will provide suppressive daily antibiotics just during pregnancy for high-risk patients who may be catheterizing or who have augmentation. There's really no correct answer, but it's a time when you may see us use antibiotics in a chronic fashion. And if you do have one of the augmentations or some other type of urinary reconstruction, all these things happen and it may get worse during pregnancy. Sometimes dosages of medications change. Sometimes you can have stones, sometimes diarrhea, metabolic issues. So just be vigilant. Let your providers know anytime you think that something's going on that's different. And what kind of delivery can you have? Well, this is where having the knowledge of what happened before can be really valuable when I'm helping counsel you about having a vaginal childbirth or having a cesarean section. I can help counsel you about, well, one of the kidneys is swollen. What does this really mean? Is there a problem with catheterization? We just have to individualize this. It's a very personal thing. It's very personal time, and we want it to be personal for you. If there have been some reconstructions below, like artificial sphincters, prior procedures that have been done specifically for continence, well, we want to know about that so we can make sure that you're going to be safe and that it's not going to worsen anything to have vaginal delivery. And if you want to have a cesarean section, we also want to make sure that we're involved. And oftentimes I'll be the one in the operating room helping your obstetrician deliver the baby, because urology involvement really is critical. If you've had these other types of reconstructions, we want to protect all the things that have been done for you and help guide decision making. You have the safest and best opportunity for success. And oftentimes that means that when you get a C-section, So the picture on the left is what we consider a classic C-section incision, but you'll get one that goes up and down the abdomen so we can really get access to the uterus above where all the bladder is. So really, I just wanted to introduce some of these things as new lessons and open the conversation for future endeavors to let you know that you're an individual and every single person is unique. And we want to individualize therapy. We want you to be able to build really good, solid, trustworthy, long-term relationships with providers. And sometimes that means opening up to very, very intimate topics. The hope is that we transition a lot of these lessons back to pediatric providers so we can begin them very, very early on, and these conversations then become quite natural. There's several centers in the United States with multidisciplinary adult clinics for spina bifida that are remarkable places to get information and be able to access care across a broad spectrum of disciplines. But really, my goal is to decrease your risk of having any kind of issues and increase your quality of life. But you deserve that, don't you? So ask questions before you get pregnant. Be cognizant of things that may have problems with latex allergies. Think about high dose folic acid supplementation before pregnancy. Understand that the one time that I might advocate for antibiotics is during the pregnancy. Caution with these tests, but ask questions. And that's why I'm here tonight, is because I encourage you, I want you to ask questions so we can give you the best information for the most successful outcomes, no matter what your goals are.
Well,
And
thank you
we have
so.
another session. Yeah.
Yes, we do have another session. So actually, we have another session on July 30th where you get to ask your own particular questions to Dr. Kaufman. It's going to be an Ask the Expert opportunity, and I'll put in the chat, I'll put in the registration. But before that, we want to take your advice and ask questions. So we have a couple of questions that hopefully you'll be able to answer before the hour. And one of them is,
Sure.
Is every 6 months about right for Botox injections?
That's an excellent question. So it's an individual response. And what I do is I will schedule patients and say, okay, we're going to do your Botox today. Then you're going to monitor the effect. Most of the time, it takes about 3 weeks or so for that effect to really set in and you to see some good results. So decreases in spasticity, leakage, those types of things. If that happens in that time frame, then I want you to monitor how long it takes for it to kind of start to come back, for your symptoms to come back. And the idea is that we pick a individual time frame where you can get your next injection before those symptoms return. So in general, I will start at 6 months, but you can have up to 400 units of Botox every 3 months. That's our max dosage that's allowed. Sometimes insurance companies won't allow that much, but that's another question altogether. But the max dosage is the max time we often use is 3 months. And so I'll have some patients who get 200 units, which is the typical dose, 200 units every 3 months. I have some that get it every 4 months, every 5 months, 6 months, 9 months, 12 months, 18 months even. So it's very individual, but 6 months is a really reasonable time frame to come into the office and get an injection twice a year. So thank you for that question.
Awesome, thank you. We have a couple more, and let's see. One of them is I'm in my mid-30s with spina bifida, and my testosterone results show it's very low. My family doctor won't do anything because she says I'm still in the normal range. She's referred me to an endocrinologist who refused me for the same reason, but I've been dealing with fatigue and low energy for the past 15 years. How can I get a doctor to get on board and get me on TRT?
That is a great question. And so our guidelines, and I encourage you to look these up for the American Urological Association, and these were informed by the endocrinological societies as well. Low normal is still in the normal range. And so most providers have a tendency to not treat a low normal value, even in someone who has symptoms. That being said, testosterone in and of itself has amazing waxing and waning values. So we have to make sure, and whenever I see someone who comes in who has they're symptomatic, but the value that they're showing me is in the normal range, is I'll repeat these tests in a very specific way. So you want to get 2 tests that are 2 weeks apart that are in early morning. So this really gives you a good baseline value and allows you to compare tests. And I often find when you repeat those, you'll be able to uncover what you've been seeking from other providers that will give them better guidance to help do replacement therapy. But it's very difficult when we have guidelines that tell us you're not really supposed to do supplementation, even for someone who is apparently symptomatic, if they have normal values. So it's a mixed bag, but get someone to repeat that test in that manner, and it may find something that's going to be helpful to you.
Thank you. And this one might be quick. In the PowerPoint, you specified oxybutynin IR. Is XR any better, or should that also be avoided?
So in general, it is a little bit better because it doesn't have the same penetration it doesn't have the same risk factors, but some of that is because of the way it was studied. So it does have less side effect profile than immediate release. There's no question for regards to things like dry eyes, constipation, dry mouth. And so we believe that it probably has less side effect profile from penetration into the brain and causing cognitive issues. That being said, it would still be on the lesser preferred agents. And I would encourage a patient who came in on oxybutynin extended release to consider moving to one of those other types of agents to protect them from any kind of further significant neurologic decline.
Okay, thank you. And we have one last question, and if we cannot answer it fully, then maybe we can answer it fully during the Ask the Expert. But maybe for now, the question is an artificial sphincter a good or safe option for older males, late 40s or 50s? Is it worth the surgery?
So I think that if I was to do only one surgery for men, it would be artificial sphincters, because in general, they are so effective and well tolerated and can provide such an incredible enhancement to quality of life. There's a lot of factors to consider. One is what type of leakage is occurring. If it is just primarily stress leakage, which can occur because of so many different issues, then an artificial sphincter is an absolute gold standard treatment. But the urodynamics testing that I mentioned really helps me discern, especially for men in their 40s or 50s, what the primary issue is, because we may go in other directions. But I do have a lot of patients who have spina bifida, spinal cord injuries, those types of things, who we can successfully use artificial sphincters, even if you're performing intermittent catheterization and do this for long periods of time. So yes, it can be in individual circumstances. I don't know exactly what would be right for you, but I think overall it is a very successful operation, and it is an outpatient surgery. So it's not a large inpatient surgical procedure that you have to stay in the hospital for days.
Thank you, Dr. Kaufman, and thank you all for attending this session of important information for your health. And hopefully, if you have questions, you have had them answered. And if you have not, remember, there's an Ask the Expert session July 30th, Tuesday, 7 p.m. Eastern Daylight Time. You will have opportunity when you register to ask your questions at that time or to ask your questions during this session on the 30th. And again, thank you to our sponsors, Attendus, WellSpect, and Hollister.